Welcome to Smoke and Mirrors, the podcast that cuts through the noise of the many policies and regulations that affect American agriculture. Each week, we pull back the curtain on the programs, policies, and perceptions shaping the agricultural community in rural America. If you've ever felt like something doesn't add up, you're not alone. I'm Jenny, and this is Smoke and Mirrors. Let's make sense of the maze we call farm policy.
Welcome to Smoke and Mirrors, the podcast where we make sense of agricultural policy. Today, I'm excited to be joined by Paul Lee, who's going to talk about accountable food as medicine. Before we get into what that is, Paul, do you mind introducing yourself?
Absolutely, Jenny, and thank you very much for the opportunity to do this. I appreciate it very much. We actually will be talking about some agricultural issues, even though we'll also be talking a lot about medicine as well. And this is how the two are meeting together. So I started a healthcare consulting firm 31 years ago. And I have an office in DC and an office in Ohio. And we work with healthcare organizations across the United States on policy issues impacting hospitals, nursing homes, surgery centers, physician groups, other organizations like that. So we're really steeped in this area of healthcare. And prior to that, I worked on Capitol Hill for a U.S. Senator for 8 years. In fact, in a neighboring state, it was Don Nichols from Oklahoma. I was with him for 8 years. I know there's quite a rivalry, between Oklahoma and Kansas, but that's just in sports.
It's worse between K-State and KU, actually.
Well, that is true.
That one is serious. Yeah.
That is very serious. You are right about that. It's just like Oklahoma State and Oklahoma University, that kind of thing. And before that, I was in the U.S. Army. And I tell people I had the very best job in the U.S. Army. I anchored the evening news for the American Forces Television Network in Frankfurt, West Germany. So, it was a long time ago. And it was a great opportunity. I loved serving my country. It was just a fabulous time period of my young life. So that's a little bit about me. And I really want to talk about obviously what we're doing in this accountable food as medicine space.
Yeah, that would be terrific. And I've had a couple different people on the podcast. I had a physician who talked about just trying to learn about chronic disease. I know in agriculture, we've always, talked about nutrition and food policy. And I think that discussion has broadened quite a bit, especially with the rise of the MAHA movement. So anyway, I'm excited to dig into accountable food as medicine. Do you mind just starting off with the very basics? What is this?
So food as medicine has been around for several decades. The idea that the food that we eat, we should consider it akin to medicine, whether it's prescribed medicine, over-the-counter medicine, but it is literally loaded with nutrients and other natural chemicals that are can be so good for the human body. And really directly connected to our health. So food as medicine, just as an overall concept, has been around for a long time. And the pioneering work that many organizations have done in the food as medicine space is really what brought us here today. I think we are at the threshold of what I would call the next iteration of food as medicine. We refer to it as accountable food as medicine. So what does that mean? What is accountable food as medicine? Accountable food as medicine is an idea or a concept that when we have a program that is designed to help an individual reverse or prevent a chronic disease, and I'll talk more about chronic diseases in just a minute and how all this weighs in, comes in together. We want to make sure that is a program that holds all stakeholders accountable. It holds the patient accountable, the providers, the hospitals, the doctors, farmers, certainly the payers, holds them all accountable, not unlike in our current healthcare system, where if you have health insurance, whether it's Medicare, Medicaid, or commercial insurance, and you're getting that insurance in large part because the insurer or your employer, whoever's paying for it, the government, whoever is paying for it, they believe that there is accountability, meaning that the doctor is going to prescribe exactly what you need, or at least what they think you need, at the time, that the doctor, him or herself, is going to be acting in your best interest as the patient to keep you from getting sicker And so
Right.
all these accountability and the medicines that you take that are prescribed to you, these are the insurers believe that these things work, that they work. The way that they are prescribed to work, they work. And so there's accountability that's built into that system. In the same way, if we want food as medicine to become considered a clinical intervention to help prevent or reverse a chronic disease with a patient, then that program is going to have the same level of accountability to, again, the providers, those who are making the medicine, the farmers, the whole agriculture system, and the payers. In my opinion, I define success in an accountable food as medicine initiative, which we're right in the beginning of this process, but we define success as it is a food as medicine program that is viewed as a clinical intervention and therefore worthy of reimbursement through health insurance, Medicare, Medicaid, commercial insurance. Then we're successful. Then we have been successful. But to get to that point, it's going to take a lot of work, and we're not there yet. We're just at the front end.
A lot of that sounds like good policy design, the well-designed, effective policy. That's something, in economics, and I do applied economics, applied research. A lot of our work is evaluating policies. What's their impact? Do they do what they're intended to do? It sounds like there have been a fair number of trials of food as medicine or food prescriptions. Could you summarize the results of those?
I sure can. In the last couple of years, had an opportunity to read and review dozens and dozens of peer-reviewed studies, other analyses as to the efficacy of food as medicine. Does it work? Does it make a difference? One of the areas that we look at where there's a lot of research that's been done already is in two programs that are funded in a part by the federal government, and that is prescription produce and medically tailored meals. They've been around for a while. And I'll give you a medically tailored meal is when an individual is admitted to a hospital for whether it's cancer surgery or some kind of procedure, and it is determined by the clinicians who are overseeing that patient that, we really need to try to put this patient on a meal program that includes healthy food for the next 2 weeks, 6 weeks, 12 weeks. I think sometimes it can go as far as 6 months because that will help the patient heal faster and prevent readmissions to hospitals, back to the hospital after several weeks or, those kinds of things. And in fact, the studies show that to be true. And what that means is that after a patient has gone through an ordeal like that, medically tailored meal program will literally heal the patient and save money at the same time. Because instead of that patient ending up back in the emergency department because they weren't taking care of themselves after discharge, they don't end up back in the ED, at least not during the time period where they're getting this really healthy food. So a lot of studies in that space. Prescription produce has been around for a number of years as well. This is where a physician decides that a patient really needs to be on a healthier food regimen for their own health, to improve their health. And they can literally write a prescription for food. Usually it's produce for that patient and start increasing their produce consumption, fruits, vegetables, etc. And the studies on prescription produce also show very, very positive results. All of that is fantastic. So what can we do to take that to the next level? That's really the question. Remember, I'm measuring the next level as, well, then it's going to be paid for by the insurance companies. And right now, the insurers continue to tell me and others that they just don't have the confidence in our current programs to be able to literally pay for a food as medicine program for an individual who has numerous metabolic disorders, everything from, a high blood sugar, a concentration of blood sugar. We refer to the measurement as the A1C, or hypertension, high blood pressure, which is a killer also, obesity. You throw heart disease in there, which is also a metabolic disorder, usually a metabolic disorder. Those 4 conditions alone drive the vast percentage of healthcare in the United States. So one of the things we look at in this, really quite simply, is why is the cost of healthcare so high? Okay, I represent hospitals. I represent physicians. I represent other parts of the healthcare system. And I will say publicly, and I'll say it everywhere, healthcare costs too much money. I don't think there's anybody that disagrees with
Could you
that.
disagree with that?
Yeah, exactly. It
Yeah.
costs too much money. And everybody's pointing the finger at everybody else and saying, you're the cause, you're the cause, you're the cause. So when I started diving into this a couple of years ago, those of your listeners who want to, research it a little bit more, go to the CDC, the Center for Disease Control. Go to their website. They have got some amazing information on that website about what drives the cost of healthcare. 90% of our $5 trillion annual healthcare bill, $5 trillion annual healthcare bill in the United States, 90%, according to the CDC, 90% can be directly tied to chronic diseases. And the four that I've already mentioned are the lion's share of those chronic diseases. It's amazing that as many people in the United States uh, have diabetes. 35 million Americans are diabetics. 35 million. It's a little more than 1 out of 10. And so there's that. Then there's the estimated 100 million people who are pre-diabetic. In other words, they're on the wrong track. I was there myself. I will talk about that in just a minute. I'm a case
Yeah.
study here on food as medicine. So, the thing is that 60% of Americans have at least one chronic disease, 60%. 42% have two or more. 90%, if you're over 65 years old, 90% of you have at least one chronic disease. And that incidence level is growing every single year. It's what's driving the cost of healthcare. So I like to tell people, what comes first, the patient or the bill? It's the patient. Hospitals aren't just sending bills out willy-nilly. They're providing care to a patient who has presented into the hospital, and they're providing the care that's needed. We have become an incredibly sick nation. The illness level in the United States is it's very sad how severe it has become. And especially in this area of what we call metabolic disorders, blood sugar, obesity, blood pressure, heart disease. Those are prevalent in the United States and growing. How many studies have you seen recently in the past few months about the number of younger people in their 40s getting colon cancer and other types of cancer that did not happen at that early of an age? There are at least 13 types of cancer that are directly tied to obesity. 13. I
Yeah.
mean, it is really, really sad. So what are we going to do about that? That's really the question. We can no longer talk about managing these diseases, because when you manage the disease, that means the people still have the disease, and pharma and all the hospitals and they continue to make money because they're managing that disease. We no longer want to just manage the disease. We want to prevent and reverse. And that means moving the debate way upstream. While the medically tailored meal program, for example, is fabulous, that program doesn't start until you're actually in the hospital and you've had a procedure and, let's try to help you out. We want to keep you from going into the hospital in the first place. So that's the idea behind all of this. It is taking agriculture interests, healthcare interests, bringing them together and improving the health of people and reducing the cost of care overall.
Right. I'd like to dig into a couple things with where we are. One is I think it sounds like we have good evidence that it works.
But it works.
And so there's some scaling up that needs to happen. It sounds like the insurance companies want more evidence. So I'd like you to talk about that. And I think what may be related too is if you do it sounds like you could do this in a way that addresses the money this kind of food can be difficult to afford right now. But then there's also sort of the education, habit building, and time component. So could you dig into those aspects a little bit?
Absolutely. Let me take the last one first because it kind of builds into this. When I first started digging into this myself a couple of years ago, the idea that a lot of the immediate pushback from people who were also like me uninformed at the time was that, oh my God, that'll take decades. We don't have decades. I mean,
Right.
obesity is a 50-year problem, like smoking, right? What we have learned by there are organizations that are doing this around the country today in a very small way, but growing. And what we have learned is that you can literally reverse, certainly prevent, but reverse a number of chronic diseases in less than 6 months. Literally reverse. So I've seen numbers where an uncontrollable diabetic. They have an A1C of 9 or higher, and they just can't seem to get, their situation under control, sometimes even with medication. And I have seen within 3 months, I've seen where the A1C has dropped by 2 points. They're still diabetic, but the severity is less and it's now controlled. And so obesity is the same way. Hypertension is the same way. You can literally, in a relatively short period of time, for those who are more severe, and we're talking about tens of millions of people in this situation that are in severe situations, and they're taking drugs, legal drugs, and they are trying to deal with, their condition. They're paying a ton of money, or their insurance company is paying a ton of money, either way. But you know what? They're taking these drugs, they wake up every morning and they're not feeling a lot better. They're just not feeling good. Because,
Right.
a lot of seniors, for example, 65 and older, the average senior is on at least 8 different medications.
You're
And for those of
joking.
you,
I have not
oh,
heard that statistic.
that's the average. That is the
Okay.
average. You've seen there are some seniors out there that are on 13, 15, 16 different drugs, and they might have 4 or 5 different physicians. And sometimes the drugs actually, it's harmful to take some of those drugs at the same time. But the bottom line is that that's not the answer. Drugs, they're not the answer. They're trying to manage the symptoms. They're trying to manage the situation. They are not reversing or preventing. And that's really where we need to be focused. And that's where food as medicine is all about. So that's number one. Number two, I was under the impression a couple of years ago that, well, the reason that people are not involved in, food as medicine is because it costs too much money. That's expensive stuff. All that produce. Oh my goodness. You go into your average chain grocery store, you know, all the fresh, the way it's designed inside usually is all the fresh stuff is around the perimeter and all the boxes and jars and stuff are in the middle, right? Most stores are similar,
Yep.
to that. And the cheap stuff is in the middle, in
Right.
the boxes, in the jars. And you have seen the data, you have seen recent data where ultra processed foods that contain chemicals from coal and oil and other what I would consider not really, stuff you ought to be putting in your body are built into that food. And that our government has allowed that over the years to be done. And part of the reason, well, they can make it cheap. Here's the problem. The first problem with that is that, yes, they can make it cheap. And so people buy that. That's what they eat. But what happens? They end up getting sick and end up costing the healthcare system and therefore the nation a lot more in the end. So we would be wise as a nation to be investing in prevention and reversal as opposed to, well, we'll fix them when they fall apart, right? So that's a huge issue in and of itself. But here's the other point that I've learned is that I've had individuals come to me and tell me that they go to their local farmers market and the produce that they get there is not a lot, is less expensive than what they get in their local store. So I think it's changing. And whether that's through local farming, generative ag, regenerative farming, and other less expensive ways. Because when you are buying your food from the grocery store, oftentimes the shipping costs are very, very high. Trucking and whatever. I mean, it's very, very high. And I don't know, we'll ever be able to get away from that, at least not in the short period of time. If you're using more and more local food, you're providing financial incentives for local farmers to grow more. You're helping build up the local economy. I like to tell people that what we're talking about here with accountable food as medicine is literally saving the family farm across the United States. I grew up in Oklahoma, your neighbor in Kansas. And I remember not only in Oklahoma, but working for one of the U.S. senators from Oklahoma many years ago, a lot of discussion about the demise of the family farm. And what does that really mean? Well, it means that they don't have markets to sell to in which they can make enough money to continue to stay in that business. And so they get out. We need to, and I think this is what happens when you are using more and more local produce, for example, you're going to financially incent farmers to stay in business and to grow their business. And the cost of that food will continue to come down as a result. And so we're hopeful that this is the beginning of, and it's already started around the country, but it's the beginning of literally a brand new market for farm families across the United States. I'm very hopeful that that's what we're looking at here. And I'm starting to see it in various parts of the country. And when we talk about accountable food as medicine, have to talk about this because it's really, well, where do you get the medicine from? It's from the farmer, right? It's from the rancher that uses regenerative ag principles for their cattle and other meats. I mean, it's not just produce; it's across the board. And so there are, it's very big. I will say this: I didn't realize this either. There are regen ag farms almost in every state in the United States. There are food hubs all over the country that become the source of, if you will, more produce. As an example, again, produce that people can buy, and the more that happens, the more money flows into that kind of production. Let's save the family farm.
We're still talking about it. That's for sure. I think that the cost of production side is pretty complicated. One thing
It is.
did want to get to, and so if you have families that are cash strapped, maybe working 2 or 3 jobs where convenience really matters, or maybe they just don't want to spend a lot of time cooking.
I understand.
How do these programs account for that?
So this is a whole cultural shift issue. We have grown up in the instant food culture, and we're still there. We're still in the instant food culture. But you can begin to see this shifting, and it needs to be a cultural shift. You see it, and it happened before RFK Jr. and his whole team over at HHS were put into those positions. But when RFK became HHS secretary, it's the first time I've been working in and around the federal government for 45 years, and I can tell you that this is the first time that I have seen an alignment along these issues among the top, the secretary of HHS and all the leadership across this government focused on healthy food being the solution, if you will, to the dilemma that we're in. So they have started, the federal government has started going after ultra-processed foods, defining chemicals that should not be in our foods, forcing those So we're starting to see some significant changes there, which is very, very exciting because what happens is it will force the food companies, the manufacturers, to think about healthier components. I've seen a lot of media coverage around, the food companies say, well, they do this because it's really inexpensive and we need to provide an inexpensive source of food for people around the world, including, of course, the United States. Now they're finding alternatives that are natural alternatives to the oil-based food dyes, for example. Now, I'm not an expert in that space, but I'm seeing these changes by regulation, by browbeating, by whatever ability the government has to get companies to change the way they operate. But it's going to require a massive cultural shift. And we're just within the first few years of that actually starting. On the more conservative side of the political spectrum, you see the MAHA movement, Make America Healthy Again, and the MAHA Moms, and all the influencers who are out there who are promoting, whether, I will say this, you can criticize this effort all day. Well, they didn't get this one quite right. They didn't get that fact quite right. But you know what? I'd rather take 80% any day of the week than 0.
80%'s not bad.
Exactly. I'd rather be mostly right on this because nothing is ever 100%. And I give this administration an incredible amount of credit for taking on a lot of very entrenched interests in this space. So, it's the beginning of a multi-year effort to change the culture. Are we going to change everybody overnight? No. I just noticed I sent to a bunch of colleagues of mine the announcement that McDonald's had a brand new 1,000 calorie sandwich they had just put into their menu. And I'm thinking, okay, this is not really going in the right direction from the perspective that I'm speaking from. But I think the point is that the reaction, just like smoking, you see somebody light up, a cigarette today in public, and now people are looking at them like, that person got a problem.
Yeah.
So 9% of adults now smoke. You know what? In 1943, 44, in the United States, 48% of adults smoked. 48%.
Yeah.
Now it's 9%. It's because America's free. You still have the right to do it. Still, 9% is still too high. But you have the right.
Yeah.
And so it took a while. It took 50 years to get, to bring that number down significantly. Here we are in the same way with food. So I think we're on the right track.
So you talked about the produce prescriptions and the medically tailored meals. There's been some successful. What are the next
Yes.
steps for policy? I think scaling up is where you want to go with this. What are the next steps for that policy wise or working with industry?
So for the last several months, we have been working with a number of members of Congress, bipartisan, on new legislation. This legislation would create what we call an accountable food as medicine demonstration project. It would create at least 5 demonstration projects around the United States that implement an accountable food as medicine program. It'd be a bundled payment, and in the bundle is the food, of course, education, training, things like nutrition. How do you read a label, right? Cooking, smoking cessation, if it's needed. It also includes quarterly, so this would be a year-long program for an individual patient, a year-long program, and it also includes quarterly biometrics, meaning the patient would you have to have your A1C taken, weight taken, and your blood pressure taken, and see if we're making progress. There's the accountability. That's the patient accountability. That's the accountability that we need to demonstrate, again, if this kind of program works. We know it does, but I think when you have the federal government behind a program like this, and after a year or two, they say, yeah, we're looking at the data and we're seeing some significant progress here for these patients, then all of a sudden the country looks at it and says, whoa, well, maybe I should rethink this.
Yeah.
Insurers look at it and go, maybe we ought to be implementing this. I can tell you that we're talking with insurance companies around the United States. One in particular, I won't say who or where, they're a special needs program. They have 20,000 enrollees. 10,000 of them, half of them, are diabetics. And one of the VPs said on a call that I was on a couple of months ago, one of the VPs said, we've tried everything. We have tried everything. We've tried incentives. We've tried disincentives. We cannot move the needle. So we want to try food as medicine.
Yeah.
And so I think that there is a growing acknowledgement because the science is there. The studies are there, the analysis is there,
Yes.
and the demand for change,
Right.
both in terms of improving outcomes and lowering the cost of care, are driving this discussion.
Right.
This is why accountable food as medicine is the next
Right.
iteration of all of this.
Let's say there's some broader cultural shifts going on. You talked about the MAHA movement. I think there's a lot of stuff on the other side of the aisle with
There is.
different words that does a lot of overlap. So there's this cultural shift, and then there's sort of some specific interventions, maybe for people who have chronic diseases that can sort of speed things up. How do you see? I think both obviously have a role, but how would you think about those two factors in this?
It's going to take, it's going to take not just one way.
Yeah.
For example, I think the best example is, well, what about GLP-1s? You just take
Right.
Ozempic
That's a good question.
and, you're cured.
Yeah.
I mean, it's like it's the miracle drug. It
Right,
not only
right.
does heart, it does diabetes, it does weight, of course.
Right.
Right. But if you've seen the studies, people over 65 drop it before the first year is up because they get sick. They get
Right.
it's just not, it's
Yeah.
not a long-term, at least not today. It's not
Right.
a long-term solution.
Right.
I
right.
believe, for example, anybody going on a GLP-1 for metabolic disorders ought to be also enrolled simultaneously in a accountable food as medicine program,
Yep.
because what that will do over a year-long period of time is promote a lifestyle change so that if after a year you've achieved certain health goals as an individual, you will continue on without the drug and continue to maintain, whether it's weight, your diabetes, whatever it is, you'll be able to continue to see improvement. So it's not an either or, it's a both and always
Right.
when it comes to
Right.
healthcare.
And how can this use existing institutions? I mean, we have a huge local and regional food movement that's grown. It's a part of the Farm Bill now. There's the food hubs you've been talking about. We have the land grant extension system. You have nutrition educate. I mean, that's classic extension, and it's still a part of it today. We call it it's not home economics anymore, but I feel like you have a lot of existing institutions that could be a part of this.
And they should be. We are launching this month an Accountable Food as Medicine Alliance. It will bring together healthcare interests, ag interests, hopefully educational interests as well, like colleges, universities. I do want to say this about Kansas. I had the distinct pleasure of being in Wichita. It was in Wichita last summer, where through the Kansas Health Foundation and the support of K-State and other organizations, brought together maybe 200, 250 leaders across the state and brought in some folks from Oklahoma as well to talk about all of this, what we're talking about today. And the enthusiasm, I don't care if you were at the university, K-State's one of the leaders, for example, one of the national leaders in regenerative agriculture and in that movement. And that's exciting. Okay. And we need a lot more of that. But there is this movement going on in the state of Kansas that I am very excited about. And I think that, in the end, Kansas will end up being one of the national leaders in this space because of all the effort that's being made, not just from healthcare or agriculture or the universities, but all of them and other interests as well, And so it is a lot more, it takes a statewide effort. So I know, like, for example, the Kansas Health Foundation, they have a goal of trying to move Kansas that used to be in the top 5 in the United States in terms of health. It's now in the bottom 5. And they are working to try to move Kansas back up. The goal is number 1. And I think that's admirable. What's it going to take to get there? And so Ed O'Malley, who heads up that organization, he's absolutely committed to making this happen in the state of Kansas. K-State, I have, had numerous discussions with them about their involvement and their role in the Regen Ag movement, which is a big deal. It's not just for the state of Kansas. They're in December. I was very excited. I didn't know about it at the time, but I witnessed the announcement. The Department of Agriculture and the Department of Health and Human Services came out. And it was really a Department of Agriculture initiative. They announced a $700 million new program. $700 million. That's a lot of money, even in Washington. $700 million to help farmers move from traditional farming to regenerative agriculture farming. And it takes a while. It doesn't happen overnight.
Absolutely.
And you need some money to be able to do that. So there are 2 ways to get the money. Government's going to help out. And that's fantastic. They're going to do that. And the other way that I mentioned earlier is create new markets. And if the demand for produce from regenerative ag goes up, what happens? Well, more farmers get into regen ag. If they're already in it, they expand. And that is really exciting.
Yep. So I'm a part of that effort. I have working with a PhD student to look at the farm financial impacts of adopting some of these practices.
I love that.
We're all trying to do our part here.
I think that's great. Somebody said to me a year or so ago, they referred to it as soil to sell. And that's sell, CELL, soil to sell.
It would work both ways, actually.
Well, it probably would.
Yeah.
But, the concept is that if we want to really live our best, healthiest life, what do? A lot of things. But one thing is clear. We lost our way in the last 50 years. We have literally lost our way. We didn't do it on purpose. Corporate farming, I'm not going to say anything bad about it because they feed the world. But we lost our way in terms of the connection between humanity and the soil. We have to regenerate the soil. I'm no expert in this space, but I've learned enough to know that we need to regenerate our soil, microbes, and all the other things that live in that, right? So that the food that is produced is the most nutrient-dense food that can be produced. Interesting stat. By the time in your local grocery store, by the time the produce is put on the shelf in the local grocery store, on average, nutrient density has already been reduced by more than half. You buy it, you put it in your fridge, depending how you store it in your fridge, after several days, it goes down another quarter. By the time you might be eating it, it has 5% of the nutrients in there that it had when it was pulled out of the ground. That's a problem. That's no longer medicine. It's food. It'll keep you from being hungry, but it isn't medicine. And so this is where the accountability comes in for the farmer. I didn't realize this. I had no idea till I got into this. There are companies out there that work with farmers and ranchers to measure. They literally measure and have contests to determine the nutrient density of food that's grown or raised. And it's like, who's got the most nutrient dense food? Well, let's have a contest, but there are.
It's not quite a yield contest.
Exactly. I mean, and why not? I think that's fabulous. I think it's fabulous. I'd love to see a billionaire come along and say, I'm going to put big prize money up and let's see who can, create how you did it and all this kind of stuff. Because in the end, that is our medicine. In the end, that is what will save us. In the end, that is needs to be equally focused, just as healthcare is. So it's not an either or, it's both and. Once again, it is the agricultural component combined with the healthcare component to produce better outcomes and lower costs.
And so we've talked a lot about the farm level and different parts of the supply chain. I think there's also the inputs. Could you talk a little bit more about, I guess, the entire supply chain? There's the input side. There's the, wholesale, retail, manufacturing side.
Well, I'm not an expert in that space, but here's what I
Yeah.
know. Here's what I know, because it's one of the challenges that we have in creating an accountable food as medicine program. So we work with a program right now and have been associated with a program in Tulsa, Oklahoma, Fresh RX Oklahoma. They were involved in fact, she'd be a great person to talk to, the woman who heads that up. She
I
was
think
up
she's on my list.
she could be. Erin
Yeah.
Martin is her name. She's fabulous. And she's been doing this program now for 4 or 5 years, maybe five years. Another leader in this space that has even a larger program out in Oakland, California, of all places, Dr. Stephen Chen. And I've been communicating with him literally every week, it seems, over everything that's going on in this space. We're working with a couple of big hospital systems that also have programs like this as well. So we're starting to get a really good feel for what it takes to get there, right? And in the case in Fresh RX Oklahoma, their program has contracted with at least 20 local farmers, most regen ag, mostly,
Yep.
not entirely, but mostly regen ag. I could be wrong. Maybe it's all regen ag now.
What regenerative is, you don't have to be, context matters, so the label is flexible. That's another story, but yeah.
It's true, and I've learned when in this legislation that we're working on, this is a bit as an aside. How do you define regenerative agriculture? There is no definition under federal or any state law on what is regenerative agriculture. So the way we did the bill was as defined by the USDA. So we'll let them deal with it. But I think
It's not going to be easy because
it won't be easy.
You take into account local conditions. And you talk to
you're right.
farmers and they're passionate. I want to do these things. I've been doing these things, but I know my land. I know this area. I know my climate. So that's going to be fun, but it's important. It's going to be hard work.
It's important. And you can have a broadly that, from what I understand, and is you've got basically 5 principles that define what regenerative agriculture is. So in that space with this program in Oklahoma, they contract with local farmers, and either through a local food hub or just direct delivery. Twice a month, food is collected and delivered. There's a group of volunteers that help, and these food boxes are created. The individuals, the patients who are in the program, go and pick up their food.
Yeah.
They also get education while they are there. Let's talk about the patient accountability. A lot of people, you might think, and I think this is true, oh yeah, I want to get into that food as medicine program because wow, I get free food. Wow, who doesn't want free food, for a year, right?
Yeah.
Well, I think if for the program to be successful, you need to kick out those that are not adhering to the protocols of the program. Are they showing up for the 24 educational sessions?
Yeah.
Are they doing their quarterly blood draws so you can see what progress they're making? And if they're not making progress, have a counseling. Are they complying as well? Because you're driving at lifestyle change. It's doable, and it is. I will tell you, it's affordable. Anyway, I think that the issue around food collection, identifying the farmers that are committed to their own food growing process, and regen ag preferably. You throw organic on top of that, and you're really stirring up a hornet's nest. Does it have to be organic too?
Right.
I would say that in a perfect world, yes, but we're not in a perfect world yet, so we're not quite there yet.
Yeah.
But I think that, if the farmers know that they're going to get paid and they have a year-long contract or longer because they're tied to a healthcare program, right, that it incents them to continue and maybe grow. I talked to a farmer in Oklahoma that 1/3 of her produce, it's a 5-generation farm, and they've contemplated, wrapping it all up and doing something different. You hear that every day. But a third of her produce now goes to Fresh RX Oklahoma. And because of that, They're still in business. The family farm
Yep.
still operates. That's
Yep.
fabulous. So in terms of supply chain, right? The other supply chain issue, and this is a doable thing. There are companies, and we're working with one out of Massachusetts, fabulous company. It's a farm, it's a big farm, and they box up and ship. They guarantee 1 to 2 day delivery to any zip code in the United States for, basically fresh produce.
Yep.
So if it's not available locally because the farms are not there, there is another option. It's more expensive though, because the shipping costs, But I think the point is, we're looking for every way to be able to
Absolutely.
make something like this happen. Because remember, our number one goal, it's not the farmer, it's not the doctor, it's the patient. Our number one goal is to help people get better. That's our number one goal. We keep that in mind, we'll figure out a way to make it.
What do you see as the top challenge in this space? Or if you can't say one, maybe two.
I think there are two. One is scale. I mean, if we're really going to be successful in changing the culture over a period of time, we're going to have to demonstrate that this model is scalable nationally. I think the answer is it is, but it's going to take some building. It's going to take some investment. It's going to take a lot of things. But scale is, when you look at 35 million diabetics, for example, and you're thinking, or 100 million pre-diabetics, you can make the argument that every American ought to be in a food as medicine program, period, whether they're healthy or sick, because it's a lifestyle change, right? We want people to do the right thing. That's number one. Of two. The second one is it's about education. There is so much misunderstanding, lack of knowledge. You talk about regenerative agriculture, for example, here in Washington to people on Capitol Hill, and they're like, what the heck is that? And they're making America's policy, right?
Right.
And so we did a program last fall. Members of Congress and staff came in, and we brought in Fresh RX Oklahoma, their team, including one of their top farmers. And while I thought most of the discussion was going to be around the healthcare piece, no. Members of Congress wanted to know all about regenerative agriculture. What does it mean? How do you measure it? What's the difference between that and regular agriculture, non-regenerative ag,
Yep.
And a lot of hunger for information, which tells me that just around the country, there's a general lack of knowledge about everything. This is one of the reasons why we're so excited about what's going on at HHS, because whether you agree with them or not, in the food space, they pretty much get it right, and people are now talking about it. When they put the food pyramid on its head, flip the pyramid, right?
Yep.
I think they did that for effect more than anything else, but I think that it really got people talking about this. When's the last time you had a conversation about the food pyramid? Before that, 5 years ago, because it's redone every 5 years.
Yeah.
Michelle Obama had a deal about, full plates and, how you divvy up the plate and stuff like that. That got a little bit of discussion, but I haven't seen discussion around food in the last, 20, 30 years, more than I've seen in the last several months because of the upside down food pyramid. So I think that educational piece is the other big, big challenge.
And what's the biggest misunderstanding that you encounter in this space?
That it can't be done, usually said by people who know very little about what's actually going on out there. So, like I said earlier, obesity, oh my God, that's a 20, 30-year problem you're going to have to fix. Nobody gets skinny overnight. Well, GLP-1s prove that wrong, but you add the whole accountable food as medicine piece to it, and then you've got long-term solution there. So it's really about there's a lot of skepticism as well because of lack of knowledge. Some people think that we're talking about voodoo, or so you'd think we were talking about voodoo when you say this accountable food as medicine. Oh, that's for wealthy people who want to spend their money on stuff that doesn't do anything anyway. They just think it does. That's not true. And I've heard that said more than once here in Washington. Oh, that's a bunch of hokum. It's not. It's just they're uninformed. And I think that as we get the word out, as more and more people start talking about this, we will conquer that problem. We will turn that problem around. And I'd love to have a debate with somebody about whether or not 100% of what they're doing over at HHS with the food pyramid is the right thing. Love to have that debate. Give me 80% any day of the week on, in this space. Because in the end, we're still talking about making people healthier and lowering the cost of healthcare. If you leave with anything today after this conversation, it's that.
All right.
Making people healthier, lowering the cost of healthcare. That's the goal.
Absolutely. So to wrap up, you get to pick one policy. What would it be?
It would be for the government to implement an accountable food as medicine program. Because I believe while government's not the solution, we certainly don't want to create another government program. That's not what this is all about. It's about leadership. And people listen to government, both good and bad. They listen. And if government says, you know what, we're seeing some stuff here that we're pretty excited about in this. Look at the data. When government says that, supposedly non-partisan, meaning not Republican or Democrat, but who's for or against food as medicine. They don't care. They just want to see if it works, right?
Yeah.
Then insurers listen. Then employers listen. Then doctors and hospitals listen. Patients listen. That would be, my number one policy goal is to have government take this up, run with it, and demonstrate that it makes people healthier and lowers the cost of healthcare. If I said that enough today?
Makes people healthier, lowers the cost of healthcare.
You got it.
All right. Well, thank you so much for your time.
Jenny, thank you very much. I appreciate it very much.
One thing, if people want to learn more, where should they go?
There will be a website, AFIMalliance.com, that will be coming up, AFIM Alliance, AFIMalliance.com. And you can learn more about the legislation. It's not up yet, but it will be in the next several weeks. You'll learn more about the legislation, more about what government is doing. We will be posting studies and a lot of things in this space. So it'll be a one-stop shop for the policy side of how this is proceeding.
Okay. Well, thank you very much.
Jenny, thank you very much for your time today. Appreciate it.
Thanks for joining us on this episode of Smoke and Mirrors. If today made you think or see things a little differently, share it with someone who appreciates cutting through the noise. Don't forget to subscribe, rate, and leave a review wherever you get your podcasts. Thanks for spending part of the day with us. Until next time, keep asking what matters.